Okay, thank you everyone for the brief break. We are returning and reconvening the ACIP meeting, and we'll move on to the next presentation by Dr. Catherine Fleming-Dutra on Evidence to Recommendations Framework Updates for the RSV vaccine.
Good afternoon. So the policy question before ACIP today is, should Pfizer RSV vaccine be recommended for pregnant people to be given during 32 through 36 weeks gestation to prevent RSV lower respiratory tract infection in infants? And I have highlighted the dosing window of 32 through 36 weeks gestation here because this is a change from the policy question that we discussed at the June ACIP meeting. And throughout the presentation, the highlighted text denotes key points and information which have been updated since June. As Dr. Long has already discussed, the reason for this change is because FDA approved the Pfizer RSV vaccine for use in pregnant people as a single dose to be given at 32 through 36 weeks gestation to avoid the risk of extremely preterm births where there is substantive morbidity and mortality and very preterm birth. FDA considered the benefit of vaccine efficacy when the Pfizer RSV vaccine is administered between 32 and 36 weeks, outweighed the risk of vaccination, including the potential risk of preterm birth and hypertensive disorders of pregnancy. As a reminder, in the phase 2b and 3 trials, vaccination was given during 24 through 36 weeks gestation. So throughout the presentation, I will refer to the approved dosing interval of 32 through 36 weeks gestation and the trial dosing interval of 24 through 36 weeks gestation. The PICO question is listed here, and as you can see, the intervention has also been updated to reflect the approved dosing interval at 32 to 36 weeks gestation. Otherwise, the population, comparison, and outcomes remain the same. And we will go through each of the following domains of the EtR framework, and the highlighted domains, benefits and harms, feasibility, and resource use have been updated, so we'll focus our time there. The first domain is public health problem. As Dr. Long has already covered today, RSV infection is the leading cause of hospitalization in U.S. infants. Most infants are infected in the first year of life and nearly all by age 2. And 2 to 3% of young infants will be hospitalized for RSV. It is a common cause of lower respiratory tract infection in infants, and the highest RSV hospitalization rates occur in the first months of life. And all young infants are at risk of severe disease with RSV. 79% of children hospitalized with RSV aged less than 2 years had no underlying medical conditions. When asked, is RSV among infants of public health importance, the work group unanimously responded yes. So now moving to benefits and harms. Here are the outcomes, their importance, and the data sources used for grade for this vaccine. We now have data on all 11 outcomes. Data were available from 2 trials, Pfizer's phase 3 trial and an earlier phase 2b trial in pregnant people. So let's talk about how we use the data from these 2 trials in grade and the benefit and harms domains overall. For both trials, we have data from the trial dosing interval and from the FDA-approved dosing interval. The number of maternal participants by vaccine and placebo arms in the phase 2b and phase 3 trials are shown here. And you can see that in both phases, less than half of the maternal participants received the intervention in the approved dosing interval, meaning that power to assess safety and efficacy is reduced. Therefore, for grade, we use the outcomes as assessed in the full trial population with the trial dosing interval of 24 through 36 weeks, consistent with the trial design. We present the post-hoc analyses using data from the approved interval as supplemental data. So here is a summary of the effect estimates and concerns and certainty of assessment for the benefits for this vaccine, assessed at 0 through 180 days of life. As a reminder, vaccine efficacy against medically attended RSV-associated lower respiratory tract infection in infants was 51%, and efficacy against hospitalization for RSV-associated lower respiratory tract infection in infants was 56.8%. Additional data received since June are highlighted. These include the important outcomes of ICU admission for RSV hospitalization in infants, which had an efficacy of 42.9%, and mechanical ventilation with an efficacy of 100%. But both estimates had very wide confidence intervals, and thus the certainty assessments were downgraded with very serious concerns for imprecision. Additionally, we now have data for all-cause hospitalization for lower respiratory tract infection with an efficacy of 28.9% with a confidence interval that crosses the null, and thus the certainty assessment was downgraded for serious concern for imprecision. So now let's talk about the certainty of assessments for harms, and again, changes from June have been highlighted. Specifically, we have now downgraded 3 outcomes: serious adverse events in pregnant people, serious adverse events in infants, and preterm birth for serious concerns for indirectness due to the difference in the trial dosing interval compared to the approved dosing interval. We did this because 55% of the phase 3 trial population and 62% of the phase 2b trial populations did not receive vaccine doses during the approved dosing interval. There is likely less opportunity for serious adverse events during pregnancy, including preterm birth, to occur when dosing starts at 32 weeks gestation as compared to 24 weeks gestation. And in particular, the risk of preterm birth would likely be lower with dosing starting at 32 weeks than with a dosing window that starts at 24 weeks gestation. So overall, the summary of grades showed that the Pfizer RSV maternal vaccine is effective in preventing medically attended RSV-associated lower respiratory tract infection in infants with high certainty in the evidence. This vaccine may be effective in preventing hospitalization for RSV-associated lower respiratory tract infection in infants with moderate certainty. The vaccine may be effective in preventing ICU admission for RSV hospitalization in infants with low certainty. The vaccine may be effective in preventing mechanical ventilation for RSV hospitalization in infants with low certainty. The vaccine is not effective in preventing all-cause medically attended lower respiratory tract infection in infants with moderate certainty. The vaccine may be effective in preventing all-cause hospitalization for lower respiratory tract infection in infants with moderate certainty. Serious adverse events in pregnant people were balanced between the vaccine and placebo group with low certainty. Reactogenicity in pregnant people was balanced between vaccine and placebo groups with moderate certainty. Serious adverse events in infants were balanced between vaccine and placebo groups with low certainty. And preterm births were unbalanced between vaccine and placebo groups with very low certainty in the evidence. This results in an overall evidence type of very low. In grade, the overall evidence type is driven by the lowest quality of evidence for critical outcomes, and here is driven by the evidence rating for the critical harm of preterm birth being very low. So I want to take a few minutes to compare the effect estimates for benefits for each of the grade outcomes from the full phase 3 trial using the pre-specified trial dosing interval shown in the middle column, and the efficacy estimates for the same outcomes from the phase 3 trial limited to participants who received doses during the approved dosing interval of 32 through 36 weeks gestation, shown on the right. And as you can see, the point estimates are relatively similar for each of the outcomes, but the confidence intervals are much wider when limited to the approved dosing interval, which is to be expected given the smaller number of participants who received vaccination in the approved dosing interval. So let's take a minute to address the phase 3 efficacy against severe medically attended RSV-associated lower respiratory tract infection, which was a co-primary trial endpoint, but was not included in grade. The reason for this is that the workgroup chose grade outcomes a priori. Medically attended RSV, lower respiratory tract infection, hospitalization, mechanical ventilation, and death from RSV were chosen. However, severe medically attended RSV lower respiratory tract infection was, as defined in the Pfizer trial, was not rated as critical or important due to vaccine policy making. But the workgroup felt that this was important to present as part of the supplemental data in the evidence to recommendations framework. And shown here side by side are the Pfizer definitions of severe medically attended RSV lower respiratory tract infection on the left and medically attended RSV lower respiratory tract infection on the right, again, which was included by the workgroup as a critical outcome for grade. And the differences in these two definitions are highlighted in blue. This slide now shows vaccine efficacy against severe medically attended RSV lower respiratory tract infection in the trial dosing interval and the approved interval. At 0 through 180 days after birth, efficacy was 69.4% in the full interval and 76.5% in the approved interval. It's important to note that not all the 81 infants who met the severe RSV definition within 0 through 180 days after birth were hospitalized, nor did all infants who were hospitalized for RSV meet the severe definition. So moving back to harms, here is the comparison for estimates from the full phase 3 trial dosing interval, again in the middle column, compared to the approved dosing interval in the right column. Again, the point estimates for relative risk are similar, but the confidence intervals were wider. And specifically for preterm birth, you can see that the relative risk in the vaccinated group compared to the placebo group, using the full trial dosing interval, was 1.20 with a 95% confidence interval of 0.99 to 1.46, whereas the relative risk with the approved dosing interval was 1.15 with a wider confidence interval, consistent with decreased power to detect this outcome. The confidence intervals are overlapping between the two estimates. As a reminder, the workgroup chose preterm birth as a critical outcome because a trial for a similar GSK maternal vaccine, RSV vaccine, also a stabilized prefusion F protein vaccine, was halted due to an imbalance of preterm births with higher numbers in the vaccine compared to the placebo group. Those data are shown here. In that trial, there was also an imbalance in neonatal deaths, which was determined to be a consequence of the preterm birth imbalance. The imbalance in preterm births was seen in low and middle income countries, but not high income countries. And the imbalance was observed from April through December 2021, but not consistently after December 2021. The reason for the imbalance in preterm births in the GSK trial remains unclear. Now, returning to the Pfizer data, and to show these data in more detail, this table shows the number and percent of preterm birth in the Pfizer phase 3 trial for the vaccine and placebo groups for the full trial population, with doses received during 24 through 36 weeks gestation on the left, compared to participants who received doses during the approved trial, the approved dosing interval of 32 through 36 weeks on the right. As you've seen before, in the full trial, with the trial dosing interval, 5.7% of births were preterm in the vaccinated group compared to 4.7% in the placebo group. Whereas when dosing is limited to the approved interval, 4.2% of births in the vaccine arm compared to 3.7% in the placebo arm were preterm, showing that the rate of preterm birth decreased as there is less opportunity to be born preterm. And also, the imbalance between vaccine and placebo groups narrowed with the approved dosing interval. This table is set up in the same way and shows the data now for low birth weight, defined as less than or equal to 2,500 grams, and neonatal jaundice. As you can see, in the full trial population, low birth weight and neonatal jaundice were both more common in the vaccinated as compared to placebo groups, but the confidence intervals between these two groups were overlapping and the differences were not significant. When limited to the approved dosing interval, 4.1% of infants in the vaccine arm had low birth weight, compared to 3.4% in the placebo group. Neonatal jaundice was slightly less common among the vaccinated group compared to the placebo, but the confidence intervals overlapped. So at the June ACIP meeting, ACIP members requested additional data regarding the Pfizer Maternal RSV Vaccine, including the rate of preterm birth by calendar month of birth, birth by week of gestational age, percent of births that were preterm by country, and adverse pregnancy outcomes. Shown on this slide is the preterm birth rate for the vaccine recipients in blue and the placebo recipients in gray by calendar time for the full phase 3 trial population, using the trial dosing interval. Enrollment in the trial started in June 2020, and the earliest births in the trial were inevitably preterm, so the rate is high in both groups. For Pfizer, the imbalance is more prominent during August 2021 through December 2021, and then again in April through May of 2022. As a reminder, the GSK imbalance was present in April through December of 2021. Shown on this slide is preterm birth rates by calendar time in the approved dosing interval. Again, as we've already seen, preterm birth was less common overall, and the temporal patterns are less clear. Additionally, ACIP requested a histogram on the number of births by week of gestational age, which is shown here from the full phase 3 trial, with the vaccine arm in blue and the placebo arm in gray. Zooming in on this graph to show preterm births only, meaning births at less than 37 weeks gestation, we can see that the imbalance in preterm birth begins at 33 weeks gestation. So we can also look at a histogram of births by gestational age, now limited to participants who received doses during the approved interval. And again, the vaccine arm is in blue and the placebo arm in gray. And again, zooming in on the graph to show just preterm births, the imbalance is less prominent and is only clearly present at 36 weeks. ACIP also requested the percent of preterm births by country in the phase 3 trial. This slide has a lot of numbers, so I'll walk you through it, including the color coding. So shown here are the total number of births and the percent born preterm by country in the Pfizer phase 3 trial for the vaccine and placebo arms, and for the full trial dosing interval on the left side and the approved dosing interval on the right side. The numbers in blue indicate a higher percentage of preterm births in the vaccinated arm for the full trial dosing interval. The numbers in red indicate a higher percentage of preterm births in the vaccinated arm in the approved dosing interval. And then the country names in purple had a higher percentage of preterm births in the vaccinated arm for both the full trial and the approved dosing intervals. And then black indicates, the black numbers or country names indicate either balanced preterm birth rates or a higher percent of preterm births among placebo compared to vaccine recipients. It is very important to note that the number of participants varied by country, and caution should be used when interpreting rates in countries with small numbers, as some of these differ by very small counts. And importantly, the US data is listed in the last row and is now highlighted. Please note that the US was the single largest country contributing to the trial and accounted for just under half of all trial participants. Again, in the full trial dosing interval of 24 through 36 weeks in the US, 5.7% of births in the vaccine arm were preterm compared to 5.3% in the placebo arm. However, in the approved dosing interval in the US, the direction of this imbalance reverses. 4% of births in the vaccine arm were preterm compared to 4.4% in the placebo arm. So ACIP also requested data on adverse pregnancy outcomes. This table shows select pregnancy-related serious adverse events occurring at any time after vaccination, up to 6 months after delivery, for the full phase 3 trial population. Overall, maternal serious adverse events occurred in 16.2% of the vaccine arm compared to 15.2% of the placebo arm, with overlapping confidence intervals. As mentioned in Dr. Long's presentation today, FDA is requiring post-marketing studies to assess hypertensive disorders of pregnancy, including preeclampsia. And in the full trial population, preeclampsia occurred in 1.8% of the vaccine recipients versus 1.4% of the placebo recipients. Gestational hypertension occurred in 1.1% of vaccine recipients and 1% of placebo recipients. And hypertension occurred in 0.4% of vaccine recipients and 0.2% of placebo recipients. Another consideration is inflammatory neurologic events. The Pfizer Maternal RSV vaccine is the same formulation and dose approved for use in adults ages 60 years and older. Within the trials for this product among adults ages 60 years and older, a potential safety signal of inflammatory neurologic events was identified. A total of 3 cases of interest were recorded among 20,000 investigational vaccine recipients ages 60 years and older, whereas no cases were observed among placebo recipients. And the details of these cases were discussed in June during the session on RSV vaccines in older adults. No Guillain-Barré syndrome or other demyelinating events were reported in the phase 2b or 3 trials among pregnant people. And the background rate of Guillain-Barré syndrome in pregnant people is much lower than that of among older adults. In the vaccine safety data link during 2004 through 15, there were 2 cases of Guillain-Barré syndrome in pregnant people, with an incidence rate of 2.8 per million person years. So we've reviewed a lot of data here, and so in summary for benefits and harms, the work group felt that this is an efficacious vaccine that can prevent RSV lower respiratory tract infection in young infants. But there was no consensus among the work group regarding the clinical importance of the preterm birth imbalance observed in the clinical trials. Workgroup members found the following points concerning regarding preterm birth. Although not statistically significant, an imbalance in preterm births was seen in the full trial population. The trial was powered for efficacy outcomes and was not designed or powered to detect a 20% increase in preterm birth. There may have been less precise dating of gestational age in some sites and countries in the trial, but there's no reason that this should bias towards a preterm birth imbalance among vaccinated compared to placebo recipients. And the preterm birth signal in the GSK maternal RSV vaccine trial, which was also a stabilized prefusion F protein vaccine, adds to the workgroup's concern. The workgroup members found the following data reassuring regarding the preterm birth imbalance. When using the full trial dosing interval, most preterm births, 60%, were more than 30 days after vaccination, and there is no known biologic mechanism for vaccines to cause preterm birth, particularly more than 30 days after vaccination. When assessed among those vaccinated during the approved dosing interval of 32 through 36 weeks, data on preterm birth the following data were reassuring to the workgroup. Specifically, the imbalance in preterm birth was still present but lessened, and most infants born preterm in the vaccine group were born at 36 weeks. In the United States, which was the single largest contributing country in the trial, the imbalance in preterm births reversed from the trial dosing interval. So in the approved dosing interval in the US, there was a higher percentage of preterm births in the placebo recipients. So overall, the majority of the workgroup felt that the approved dosing interval of 32 through 36 weeks gestation can reduce the potential risk of preterm birth and the potential for complications from preterm birth, both by preventing preterm birth and because babies born late preterm are less likely to have complications from preterm birth. And this was their major safety concern. So when asked how substantial are the desirable anticipated effects of the Pfizer maternal RSV vaccine for the critical and important outcomes, the workgroup was split between large and moderate, with a narrow majority choosing large. When asked how substantial are the undesirable effects of the Pfizer maternal RSV vaccine for the critical and important outcomes, the workgroup responded that they were small. When asked regarding the balance of desirable and undesirable effects, the workgroup determined that the balance favored intervention. Now moving on to values. Here's a summary of the data for this domain presented in June. In a value survey of pregnant and recently pregnant people conducted during December 2022 and January 2023, 68% of respondents had knowledge of RSV prior to taking the survey. 61% of respondents said they definitely or probably would get an RSV vaccine while pregnant. And among those who did not respond that they definitely would get an RSV vaccine while pregnant, safety concerns, lack of RSV knowledge, and concerns about vaccination causing or intensifying RSV infection were the top reasons for not wanting an RSV vaccine during pregnancy. It's also important to look at the uptake of other vaccines in pregnancy. We know that in the US, coverage for recommended vaccines among pregnant people has decreased during the pandemic and varies by race and ethnicity. Tdap vaccination coverage was 53.5% in the 2020 to 21 season and 45.8% in the 21 to 22 season. Rates of Tdap coverage were higher in white non-Hispanic women than among Black non-Hispanic women during the 2020 to 21 and 21 to 22 seasons. When asked whether the workgroup felt that pregnant people feel the desirable effects are large relative to the undesirable effects, they answered probably yes. When asked, is there important uncertainty about or variability in how much pregnant people value the main outcomes, the workgroup was evenly split between probably important uncertainty or variability and probably not important uncertainty or variability. So moving on to acceptability, and I'll note that there are limited data to inform this domain and no updates since June. A study in England assessed support of an RSV vaccine among maternity healthcare professionals, specifically obstetricians and midwives, if it was routinely recommended. And 47% definitely and 34% likely would support a routinely recommended RSV vaccine. When asked, is RSV prevention with the Pfizer maternal RSV vaccine acceptable to key stakeholders, the majority of the workgroup answered yes, with a minority answering probably yes. So moving on to feasibility. The storage and handling requirements are listed here. Additionally, most pregnant patients receive Tdap vaccine in an obstetrician's or midwife's office. Therefore, it is likely that pregnant patients would also most often receive RSV vaccine at their prenatal care provider's office. Another important consideration for feasibility is simultaneous administration of RSV vaccine with other vaccines in pregnant people. Pregnant people may potentially be eligible to receive RSV, Tdap, COVID-19, and influenza vaccines at the same visit. There are limited data regarding simultaneous administration, but there was a Pfizer study in healthy non-pregnant women ages 18 through 49 years on simultaneous administration of Tdap and Pfizer RSV vaccine that found decreased immune response to pertussis components, meaning that non-inferiority criteria were not met. However, given the lack of correlates of protection for pertussis, it is unclear how this might impact protection against pertussis from maternal Tdap when simultaneously administered with RSV vaccine. Tdap is recommended every pregnancy, preferably during the early part of gestational weeks 27 through 36, which means that Tdap would preferably be given before 32 weeks and RSV vaccine would be given at or after 32 weeks. However, in market scan data from 2018 through 2021, about half of captured Tdap doses were given before 32 weeks gestation. Another important consideration is that RSV vaccine is one of two available preventive products for RSV in infants. Either RSV vaccination during pregnancy or nirsevimab administration for the infant after birth can be used to prevent RSV disease in infants. But the workgroup felt strongly that both products are not needed for most infants. The pregnant person and their prenatal care provider will need to make the decision during pregnancy regarding which RSV prevention product to use. Many prenatal care providers may not have time to discuss options for RSV prevention with their patients, and prenatal care providers may not feel equipped to discuss nirsevimab, as this product will be given to the infant after birth. Regarding the timing of RSV vaccine dosing during the calendar year, RSV vaccine dosing could be implemented for pregnant people as a seasonal campaign or year-round. The workgroup unanimously supported use of a seasonal dosing strategy for maternal RSV vaccine because this would maximize cost effectiveness and maximize benefits for infants. And it targets RSV vaccine dosing to infants who will be in the first months of life during the RSV season. And importantly, another product, nirsevimab, is available for infants who are born out of season, for whom maternal vaccine protection would have waned by RSV season. The workgroup supported seasonal dosing beginning in September and going through January in most of the continental United States based on typical or pre-pandemic RSV seasonality. This aligns with implementation of influenza vaccine and thus would simplify implementation for prenatal care providers. The workgroup felt that jurisdictions in which RSV seasonality differs from most of the continental United States should have flexibility regarding start and stop of administration of RSV vaccine in pregnant people. And these jurisdictions include Alaska and jurisdictions with tropical climates, such as those listed here. So when asked, is the Pfizer Maternal RSV vaccine feasible to implement, the majority of the workgroup answered yes, and a substantial minority answered probably yes. Next is resource use domain, and you just heard presentations from Drs. Hutton and Ortega-Sanchez on economic analyses, so I will be brief. But importantly, I wanted to draw your attention to this slide that Dr. Hutton showed earlier, which shows scenarios for cost effectiveness by months of RSV vaccine dosing during the calendar year. The base case is shown in the first bar at about $400,000 per quali. And if the months of dosing are limited to target dosing to pregnant people whose infants will be in the first months of life during the RSV season, the incremental cost effectiveness ratio, or ICER, decreases, meaning that the cost effectiveness improves. And importantly, you can see the ICER for providing doses during September through January. The workgroup's preferred dosing timing is $167,000 per quali. RSV vaccine may improve RSV outcomes, but it will also increase costs. The base case model showed an ICER of about $400,000 per quali, and the base case assumed year-round dosing of this vaccine and typical RSV seasonality in most of the continental United States. The workgroup felt that this vaccine would not be cost-effective under the base case conditions. However, cost effectiveness would be improved by using a seasonal dosing strategy during September through January in most of the continental US. Thus, as we have discussed already, the workgroup unanimously supported the use of a seasonal dosing strategy. When asked, is Pfizer maternal RSV vaccine use a reasonable and efficient allocation of resources, the majority of the workgroup answered yes, and a substantial minority, probably yes, and a substantial minority answered yes. However, it is very important to note that the workgroup responses were based on seasonal dosing for RSV vaccine, specifically September through January in most of the continental United States. The last domain is equity, and these data have been presented before. National studies of death certificates found higher rates among non-Hispanic Black children compared with non-Hispanic white infants and children aged 1 through 4 years. ICU admission rates for RSV among non-Hispanic Black infants less than 6 months old were 1.2 to 1.6 times higher than among non-Hispanic white infants. In one study, RSV hospitalization rates were 4 to 10 times higher among Alaska Native and American Indian children ages less than 24 months than the rate in the general population. However, it's important to note that this study was limited to specific populations and might not be broadly representative of risk in all Alaska Native and American Indian children. Regarding insurance coverage of pregnant people by Medicaid and of coverage of vaccines during pregnancy, by federal law, all states provide Medicaid coverage for pregnancy-related services to pregnant women with income levels up to 138% of the federal poverty level. In 2021, 41% of mothers had Medicaid at the time of birth, making Medicaid the largest payer for maternity care in the United States. If recommended, ACIP will vote on a Vaccines for Children resolution for this vaccine for pregnant people aged less than 19 years. And beginning on October 1, when the Inflation Reduction Act provisions become effective, state Medicaid agencies will be required to recover vaccines and their administration without cost sharing for nearly all full benefit adult beneficiaries covered under traditional Medicaid if the CDC ACIP recommendations apply. Regarding other insurance coverage, meaning commercial insurance for vaccines during pregnancy, under the Affordable Care Act and its implementing regulations, ACIP recommendations that have been adopted by CDC and are listed on CDC's immunization schedules generally are required to be covered by group health plans and health insurance issuers without any cost-sharing requirements. So when asked what would be the impact of the Pfizer maternal RSV vaccine on health equity, answers ranged, and there was no clear majority. The most common answer among the work group was probably increased. The second most common was probably no impact, and the third was increased. So in summary, regarding the use of the Pfizer maternal RSV vaccine to prevent RSV in infants, the work group judged this is an important public health problem. The desirable anticipated effects are large. The undesirable anticipated effects are small. The balance of desirable and undesirable effects favor the intervention. They judge that the target population probably feels the desirable effects are large relative to the undesirable effects. Half of the work group chose that there is probably important uncertainty or variability in how patients value the outcome, and half chose there is probably not important uncertainty or variability. The intervention is acceptable to key stakeholders. The intervention is feasible to implement. The intervention is probably a reasonable and efficient allocation of resources with seasonal dosing, and the work group had varied answers as to whether the intervention would increase health equity, ranging from probably no impact to increased health equity. The majority of the work group felt that the desirable consequences probably outweigh the undesirable consequences in most settings, and a substantial minority felt that the desirable consequences clearly outweigh the undesirable consequences in most settings. The majority opinion was in favor of recommending the Pfizer maternal RSV vaccine, and there was a minority opinion to recommend the intervention based on shared clinical decision-making. So I want to summarize the work group considerations overall. So for benefits and harms, the majority of the work group is supportive of the intervention with the Pfizer maternal RSV vaccine for pregnant people with the approved dosing interval of 32 through 36 weeks gestation. They found the data on preterm birth, when assessed among those vaccinated during the approved interval, to be reassuring. They felt the approved dosing interval reduces the potential risk of preterm birth and the potential for complications from preterm birth, which is their major safety concern. And all workgroup members endorsed the importance of post-introduction vaccine safety monitoring. The workgroup unanimously supported use of a seasonal dosing strategy, which would maximize benefits and cost effectiveness. The workgroup supported RSV vaccine dosing should occur during September through January in most of the continental United States, and felt that jurisdictions in which RSV seasonality differs from most of the continental U.S. should have flexibility regarding start and stop administration of RSV vaccine in pregnant people. The workgroup considered the implications of RSV vaccine being one of two available preventive products for RSV in infants. The workgroup expressed that pregnant people should have options for RSV prevention, as nirsevimab may not be readily available in all settings, and pregnant people and their providers may have preferences regarding these two products. The workgroup also stated that pregnant people should be made aware that they can either receive RSV vaccine during pregnancy or nirsevimab can be given to the infant, but most infants will not need both. The workgroup expressed that pregnant people should be informed regarding the risks and benefits of both products before making a decision. The workgroup had extensive discussions regarding a full recommendation versus a shared clinical decision-making recommendation. Most workgroup members support a full recommendation. They felt the approved dosing interval reduces the potential risk of and complications from preterm birth. They stressed the importance of clear vaccine recommendations. They noted that providers who will help pregnant people decide which product to receive generally have less familiarity with the data than ACIP does. They expressed that shared clinical decision-making recommendations can be confusing, hard to implement for providers, can lead to lower vaccine confidence and uptake, and could potentially influence support for the vaccine in lower and middle-income countries where nirsevimab may not be available. A minority supported a recommendation with shared clinical decision-making. They noted that without shared clinical decision-making, a full recommendation could result in some providers recommending RSV vaccine during pregnancy without discussing with pregnant patients that nirsevimab is an option. They cited the potential risk for preterm birth and neuroinflammatory events, and cited that the same vaccine is recommended under shared clinical decision-making for adults ages 60 years and older. It is important to note that ACIP generally makes shared clinical decision-making recommendations when individuals may benefit from vaccination, but broad vaccination of people in that group is unlikely to have population-level impacts. And lastly, as we discussed in June, the workgroup noted that currently there are no data available on the efficacy of the first lifetime dose during subsequent pregnancies, nor the safety of additional doses given in subsequent pregnancies. The workgroup felt that it was too early to decide whether additional doses should be given in subsequent pregnancies given the lack of data. And additional data are needed to inform whether additional doses in subsequent pregnancies would be indicated, and recommendations can be updated in the future. The proposed voting language for today is: maternal RSV vaccine is recommended for pregnant people during 32 through 36 weeks gestation using seasonal administration to prevent RSV lower respiratory tract infection in infants. I would like to acknowledge my co-lead, Dr. Jefferson Jones, and the many others who contributed to this presentation. And before we pause for questions, I will turn it over to Dr. Jones, who will discuss clinical considerations.
Well, switching over, could I do a quick sound check?
We can hear you, yeah. I'm just hoping the committee can stick with us. I have to say that was a lot of information. But Dr. Jones, please go ahead. And I think actually after this, we might want to pause for some questions because I do feel like there's a lot of questions on the table.
Thank you. Well, I'll discuss the proposed clinical considerations for the use of the maternal RSV vaccine and nirsevimab. And so first will be the proposed clinical considerations for use of the maternal RSV vaccine, and Dr. Fleming Dutra reviewed the workgroup discussion points that shaped these considerations. So as proposed, the maternal RSV vaccine is recommended for pregnant people during 32 through 36 weeks gestation with seasonal administration, or during September through January in most of the continental United States, in jurisdictions with seasonality that differs from most of the continental states. For example, Alaska and jurisdictions with tropical climates such as the parts of Florida, Hawaii, Puerto Rico, Guam, U.S. Virgin Islands, and the U.S. affiliated Pacific Islands. So in these jurisdictions, providers should follow state, local, or territorial guidance on the timing of administration. The maternal RSV vaccine may be simultaneously administered with other eligible vaccinations. Before reviewing the clinical considerations for use of both the maternal RSV vaccine and nirsevimab, I would like to summarize considerations of the work group. I will first discuss two groups of infants born to vaccinated mothers that we previously considered for nirsevimab during the June ACIP meeting: preterm infants and infants born outside of the RSV season. So as proposed, regarding infants born prematurely, the maternal RSV vaccine recommendation is for administration beginning at 32 weeks gestation. And from the time of maternal vaccination, 14 or more days are likely needed for development and transplacental transfer of maternal antibodies to protect the infant. Therefore, the earliest an infant can be born and have maternal vaccine-induced protection is 34 weeks gestation. This means that all infants born at less than 34 weeks gestation will be recommended to receive nirsevimab. Regarding infants born outside of the RSV season, protection from maternal vaccination may begin to wane after 3 or more months. For example, this has been seen with the influenza and COVID-19 vaccines. And workgroup members were initially concerned that some infants born outside of the RSV season and born to vaccinated mothers may benefit from nirsevimab in order to boost protection when entering the RSV season. However, because maternal RSV vaccine administration is now proposed to be recommended during September through January, most infants of vaccinated mothers will be born during the RSV season or born during October through March. Mothers of infants born outside of the RSV season or those born during April through September will not have been vaccinated, and therefore nirsevimab will be recommended for these infants. Other considerations regarding the use of both maternal RSV vaccine and nirsevimab include that there are 2 products available to protect infants from RSV lower respiratory tract infection. For infants born to vaccinated mothers, the addition of nirsevimab may provide incremental protection, but there are no efficacy data on the use of nirsevimab in infants born to vaccinated mothers, so this is unknown. There are also no safety data on the use of nirsevimab in infants born to vaccinated mothers, but nirsevimab trials included infants with maternal infection-induced antibodies, and the risk is likely minimal. The workgroup felt that for most infants, administering both products is not needed, and based on the cost-effectiveness analyses presented earlier today, this would not be a reasonable and efficient allocation of resources. Of note, the documentation of maternal vaccination status may not be available to the infant's healthcare provider. Most workgroup members felt that pregnant people should be aware that both maternal vaccination and nirsevimab are options when deciding whether to be vaccinated. However, healthcare providers of pregnant people may not have the time or feel equipped to discuss nirsevimab when counseling. The workgroup felt that in rare situations, flexibility is needed for providers to be able to administer nirsevimab when it is clinically warranted to infants born to vaccinated mothers. Examples include conditions in pregnant people resulting in an inadequate immune response to vaccine or decrease in transplacental antibody transfer. Also, infants who have undergone cardiopulmonary bypass leading to a loss of maternal antibodies, and infants with sufficiently increased risk for severe disease to warrant nirsevimab because of the potential increased benefit. So the following are the proposed clinical considerations for the use of the maternal RSV vaccine and nirsevimab. Either maternal vaccination or use of nirsevimab in the infant is recommended to prevent RSV lower respiratory tract infection, but administration of both products is not needed for most infants. Healthcare providers of pregnant people should provide information on both products and consider patient preferences when determining whether to vaccinate the pregnant patient or to not vaccinate and rely on administration of nirsevimab to the infant after birth. So this slide displays potential information that could be shared with patients on the relative risks and benefits of a maternal RSV vaccine and nirsevimab. It is important to note that both products are safe and effective in preventing RSV lower respiratory tract infection in infants. Relative benefits of maternal vaccination include a maternal vaccine provides protection immediately after birth when infants are at the highest risk for severe RSV disease. A maternal vaccine may be more resistant to virus mutation compared with monoclonal antibodies, although RSV does not mutate rapidly. While both products require an injection, use of a maternal vaccine avoids injection of the infant. Relative risks of maternal RSV vaccination include maternal vaccine-induced protection is reduced if fewer vaccine-induced antibodies are produced, for example, if mother is immunocompromised, or could be reduced in transferring from mother to baby, for example, if the infant is born soon after vaccination. There is a potential risk of preterm birth, but administration at 32 to 36 weeks reduces this risk. Relative benefits of nirsevimab include studies of antibody levels suggest that protection from nirsevimab might wane more slowly. Administration of nirsevimab can provide antibodies directly if an infant receives less antibodies from the mother. And since nirsevimab is provided after birth, there are no risks of adverse pregnancy outcomes. Relative risks of nirsevimab include there is potential limited availability of nirsevimab during the 2023 to 24 RSV season. So in the setting of a maternal vaccine, nirsevimab would be recommended for infants aged less than 8 months, born during or entering their first RSV season if the mother did not receive the RSV vaccine, or it is unknown if the mother received an RSV vaccine, or mother was vaccinated, but the infant was born less than 14 days after vaccination. Nirsevimab is not needed for most infants born 14 or more days after maternal vaccination. Nirsevimab can be considered when the mother has received an RSV vaccine 14 or more days prior to birth in rare circumstances when, for the clinical judgment of the healthcare provider, the potential incremental benefit of administration is warranted. For example, infants born to pregnant women or pregnant people who may not mount an adequate immune response to vaccination, for example, people with immunocompromising conditions, or have conditions associated with reduced transplacental antibody transfer, for example, people living with HIV infection. Infants who have undergone cardiopulmonary bypass, leading to a loss of maternal antibodies, or infants with substantial increased risk for severe disease. For example, hemodynamically significant congenital heart disease, or intensive care admission and requiring oxygen at discharge. Recommendations for nirsevimab can be summarized in the displayed algorithm. Nirsevimab is recommended to all infants aged less than 8 months on the day of administration that meet all 3 of the following criteria. First, either the mother did not receive an RSV vaccine during pregnancy 14 or more days prior to birth, or the maternal RSV vaccine status is unknown. The rare exceptions, as presented in the previous slide, are described in a footnote included in the next slide. Second, the day of the nirsevimab administration is during October through March, which applies to most of the continental United States. Details on timing, including special situations and flexibility, are described in a footnote in the next slide. These were previously presented during last month's ACIP meeting on nirsevimab and described in the published nirsevimab recommendation in the MMWR. Third, the infant has never previously received a dose of nirsevimab. If all 3 criteria are met, the nirsevimab is recommended. If any criteria are not met, the nirsevimab is not needed. For children aged 8 through 19 months, recommendations are unchanged from what was presented last month and published in the MMWR, as they are the same regardless of maternal vaccination history. A similar algorithm for use of nirsevimab to children aged 8 through 19 months on the day of administration is available in the extra slides. This slide displays the footnotes discussed in the last slide. And okay, I'll turn it back over for potential questions.
Thank you. Sorry, those were complex presentations. I recognize we also have implementation. Let me just ask the room real quickly. Would the implementation presentation be helpful for the conversation as it relates to the implementation domain, Dr. Peacock?
I'd say yes, it would help me.
Okay. Dr. Long, did you have a question or a comment right now?
I think I'll wait till the implementation. I agree.
Okay. Well, why don't we then go ahead with Dr. Peacock presenting on implementation considerations for maternal RSV vaccine.
So I'm pleased to be here to talk about the maternal RSV vaccine implementation considerations. And so I'm going to go over these different implementation considerations. I won't read through this list, but you'll see these over the next few slides. So first, for Pfizer RSV vaccine storage, handling, and administration, you'll see here that the vaccine is overall clinical implementation is similar to other vaccines. It's administered as a single dose through an IM route. The proposed recommendations to ACIP allow for simultaneous administration with other recommended vaccines. And there is some consideration that increasing the number of vaccines could lead to limited storage space. The cost, there has been a lot of conversation already about cost of the vaccine. So the cost of the Pfizer RSV vaccine is $295 a dose, compared to, for Tdap, approximately $46 to $52. This cost is lower than the infant nirsevimab cost of $495 for the private sector cost. Reimbursement and cost recovery challenges have already been identified by providers and practices as an implementation barrier for maternal immunization. And you'll see that on this slide here, that when looking at the different provider concerns, financial concerns really are the leading barrier to maternal immunization. There was already some discussion, so I'm not going to go into huge detail on this related to insurance coverage. One thing I will point out is that most pregnant people are covered by some form of a payer, whether that's private insurance or Medicaid. About 4% of pregnant people are considered self-pay or likely uninsured. So if recommended, ACIP will vote on a VFC resolution for maternal RSV vaccine in people aged under 19 years of age. And then for people over 19 years of age, there would be limited availability, through the 317 programs in our jurisdictions. Insurance coverage for infant nirsevimab is so thinking about insurance coverage for infant nirsevimab, ACIP has recommended nirsevimab as a routine immunization, and therefore it will be covered under the ACA without cost sharing by the patient starting in the effective plan years. What we've heard anecdotally is that plans are starting to let people know that they will start covering nirsevimab when it comes out in the coming weeks. Nirsevimab is included in the Vaccines for Children program. Eligible children, so about 50% of children in the US, will be able to access nirsevimab at no cost. As far as supply and availability of maternal RSV vaccine and nirsevimab in this 23-24 RSV season, we don't anticipate any supply-demand mismatches. Because the Pfizer maternal RSV vaccine is the same product in use for adults aged over 60 years of age, availability is expected shortly after ACIP recommendations. Nirsevimab is likely going to be available very soon, and we anticipate this being available as soon as next week or in early October. There are efforts, and there were some conversations at the last ACIP meeting about delivery in birthing hospitals versus outpatient settings, and there are efforts underway to increase the number of birthing hospitals who will be able to administer nirsevimab, particularly under the VFC program. One thing to point out is that the increase in complexity of the maternal immunization schedule, and so you'll see here the different potential recommended vaccines during pregnancy, so influenza, COVID-19, and Tdap, and then this RSV vaccine, and seeing that there are different timings of the vaccines based on season or gestational age, a limited window for RSV administration, and it's really unclear about the willingness of pregnant people to accept multiple vaccines in pregnancy. This gives us a little bit more information, and so in a survey of pregnant people, 12% they would accept no vaccines, and if you look at those that would accept either one or two vaccines together, that's about 49%. This is another piece of information to look at uptake of vaccines among pregnant people. And this has declined as well as we see that disparities persist. One thing that is very important in the decisions as to whether to administer maternal RSV vaccine or the infant nirsevimab will be made during pregnancy. And as we know with all vaccination studies, demonstrate that healthcare providers are really that most trusted source of information on vaccines, and that provider recommendation is very strong. It's a very strong predictor of vaccination. One survey did show that 2/3 of obstetricians did not feel comfortable providing information about routine childhood immunizations, or that was their role. When we think about pediatric provider roles in immunization decisions, the pediatrician or the pediatric provider recommendation for RSV is for nirsevimab is contingent upon knowledge of maternal vaccination status, and we know that this could be challenging if the pediatric provider doesn't receive the maternal record. Verbal report of vaccines received during pregnancy may not be reliable, and therefore pediatric providers may need to make decisions on nirsevimab administration without having complete information on what happened during pregnancy. We also think about the capture of the immunization data. State IISs vary in what they capture related to adult immunization. So pregnancy status is not identified in IIS, though there is a potential way to look at the immunization information system data, because you could use adult women less than 60 years of age as a proxy for this RSV vaccine administration. There is not a way currently to link maternal and infant immunization records in immunization information systems. It's not possible through these systems at this point in time to be able to use that to forecast whether or not an infant nirsevimab immunization is needed. There are also, in some state policies, there's not an ability for pediatric providers to review adult records or records of individuals who are not their patients. There are, as there always are in immunization implementation, some communication challenges. The terms like vaccine for the maternal product versus immunization for the infant product, understanding what the potential risks and benefits are, and helping a pregnant person make an informed decision. This is something that is going to take time for providers to have those conversations. And then discussing financial implications to a patient in a setting of uncertainty related to coverage in this first year of implementation. There is a lot of work being done here at CDC. There have been formative research and message testing, so a lot of focus groups and in-depth interviews to help inform the ultimate communication activities that will be done for the public. There have been surveys of parents of young children, also pregnant and recently pregnant people. With that information, patient and provider education materials are being developed. There's also some partnerships with healthcare provider organizations, as well as those organizations that serve pregnant people, and an intention to do social media across all of CDC's platforms. So with that, I'll turn it back to Grace. Thanks.
Okay, thank you so much, Dr. Peacock. I do want to open this up for questions. I will ask the members to start to prepare sort of some of the questions you have in mind, going all the way back to the ETR. But we did have a few statements from folks. So I want to call first on Dr. Luis Jodar from Pfizer to make a brief statement. My request has got to be less than 3 minutes. Thank you.
Thank you, Dr. Lee. Do you hear me well?
We do. Thank you.
Thank you. My name is Luis Jodar. I'm the Chief Medical Affairs Officer for Vaccines and Antivirals in Pfizer. I would like to thank the committee for the opportunity to speak today. We are obviously excited about the recent FDA approval of the maternal indication for our RSV vaccine, Abrysvo. Just last fall, the United States experienced a triple epidemic of RSV, flu, and COVID-19 infections, making national headlines. With the threat of another triple epidemic, having multiple options for RSV prevention for infants will be more important than ever. As you have seen from the data in our Matisse efficacy randomized controlled trial, the maternal RSV vaccine provides infants with a high degree of protection against RSV immediately from birth, when infants are at highest risk for severe disease, and maintains this protection for at least 180 days. This is even more important when considering equity. Medicaid recipients miss or cancel a substantial proportion of their well child visits in the first 6 months of life, with only 25% attending all recommended well child visits. In contrast, more than 90% of Medicaid mothers attend at least one ANC visit prior to delivery. With an estimated 41% of pregnant individuals on Medicaid, maternal immunization provides a secure, stable, and equitable approach to RSV prevention for newborns. I also wanted to comment on the concern raised about an imbalance in preterm birth. The totality of the data supports a favorable benefit-risk profile for maternal vaccination, as supported by the external DMC committee, by the FDA VRBPAC committee, and finally, by FDA licensure. The US indication of 32 through 36 weeks is reassuring about the potential risk of preterm births. Pfizer has committed to 4 post-licensure pharmacovigilance studies. The safety surveillance systems in place through our post-marketing commitments, along with CDC and FDA systems presented today, are sensitive, timely, and powerful, and can detect any safety signals should any arise. We want to assure the committee that a robust supply of vaccine is already available to providers and ready to be implemented through existing vaccine programs. The RSV season is already starting, and for the first time, we could have, importantly, 2 routinely recommended options for RSV prevention for infants. Pregnant persons will now be able to have an informed discussion with their OBs and other maternal health providers, as they do for all routinely recommended maternal vaccines, and make an informed decision on which option is best for them and their baby. Finally, I would like to emphasize that the RSV vaccine will be a lower cost option and overall could result in lower budget impact for the US healthcare system. Pfizer would like to thank the committee and the work group for your careful deliberations and dedication to preventing infectious diseases. Thank you, Dr. Lee, and back to you.
Thank you. We also have two liaison organizations that wish to make statements that I think will be relevant to the committee. So Dr. Brenna Hughes from ACOG.
Thank you, Dr. Lee. On behalf of ACOG, first, ACOG would like to thank the leadership of ACIP and the RSV work group for their collaboration on this topic and for inviting ACOG to share our position and expert opinions regarding the maternal RSV vaccine. It is critical that the OBGYN voice be considered, particularly as implementation considerations are discussed. ACOG remains unequivocally supportive of a full recommendation for maternal RSV vaccine for pregnant individuals. This RSV vaccine is efficacious and could decrease the risk of severe disease in many infants. And while nirsevimab is clearly highly efficacious, it may not be available or may not be preferred by a parent or healthcare facility as the primary intervention. Therefore, ACOG believes it is critical to ensure that pregnant individuals can access this RSV vaccine to give their newborns protection after birth. As a practicing obstetrician and member of the RSV vaccine work group, I have reviewed these data extensively along with the other experts on the work group, and I have discussed these data with ACOG experts and leadership. We have evaluated all of the available data regarding the risk of premature delivery, and currently we consider this outcome a theoretical risk, with the benefits of vaccination outweighing the hypothetical risk of adverse events. Therefore, we feel that this vaccine should be recommended. Finally, we continue to encourage the collection of additional data to inform future policy considerations, and we look forward to collaborating with the CDC and other organizations to ensure optimal implementation of strategies to decrease the burden of RSV disease in infants. Thank you for allowing us to provide this statement, and back to you.
Thank you, Dr. Hughes. And one more statement from our colleague, Ms. Hayes at the American College of Nurse Midwives.
Yes, can you hear me?
We can, thank you. Please go ahead, Ms. Hayes.
Thank you. The American College of Nurse Midwives is the largest professional association representing certified nurse midwives and certified midwives in the United States. ACIP sets the standard for excellence in midwifery education and practice in the U.S. and strengthens the capacity of midwives in developing countries. Our members are primary care, sexual and reproductive health providers for people throughout their lifespans, with a special emphasis on pregnancy, childbirth, gynecological, and reproductive health. ACNM has participated actively in the ACIP and the CDC Task Force on Maternal Immunizations. We regularly update and encourage our members to recommend the 3 standard maternal immunizations throughout a shared decision-making model. The midwifery model of care puts women and pregnant people at the center of care and encourages members to share scientific evidence on choice surrounding immunizations so that pregnant families can make the best decision for themselves. After reviewing the evidence on the safety and efficacy of the maternal RSV vaccine, as well as the incidence of RSV cases in newborns and infants, ACNM strongly recommends that ACIP support the availability of this vaccine to all pregnant people from 32 to 36 weeks of gestation. We believe that pregnant individuals should be informed of the benefits and the risks of maternal RSV vaccine, and the vaccine should be available to those who choose it without any barrier to access, such as cost, referral, or approval by a third party. Given the rise in the prevalence of RSV cases among newborns, we believe that pregnant people should be able to access a vaccine that is proven to prevent lower respiratory tract disease and severe lower respiratory tract disease caused by respiratory syncytial virus in infants from birth to age 6 months of age. Thank you.
Thank you very much, Ms. Hayes. And with that, the series of presentations is now open for questions. So we're going to start with Dr. Long.
Yes, thank you, Dr. Lee. I'd like to make a few comments on the underpinnings of the work group considerations and recommendations for your consideration. We were very concerned about the imbalance in prematurity, and especially in the shadow of the GSK vaccine that was not pursued. And likely we would not have given or come to consensus on a non-suffixed recommendation for 24 to 36 weeks. Non-suffixed means with shared clinical decision-making. We wouldn't have been able to do that. But the data on vaccination in the 32 to 36 week age group and the information that the prematurity that occurred in the trials was an average of 4+ weeks after immunization was not associated with reactogenicity at the time of immunization, made us more sanguine with the 32 to 36 weeks. So we thank very much the FDA for making that restriction and not having us have to do that as a first potential restriction. The second restriction of the seasonal administration, although this is not terribly popular, it does go with the influenza season. And that also, for most of us, was based on a safety consideration. And that is, do not take any risk of this vaccine if there is a potential risk of prematurity, if it cannot benefit the child. And year-round administration could not benefit children born in April through September. So that was the reason for that restriction. And the next thing was the cost. So the base case, I think we would have not come to consensus for a clean recommendation or a recommendation. And it was only the seasonal use that, again, may be somewhat off-putting to some, was the only way in which this could get down to a quality that was acceptable in our minds or similar to other vaccine or preventions that have been done. So that we have come to the level of what we think is the ability to present to you a non-suffixed recommendation, and that the difference in them and what would be said to the parent considering either would be more of a choice, because shared decision-making usually is because there is a big difference in efficacy and we don't have head-to-head trials on these products, or in safety. And we have thought that there would be mitigation of the potential risk of prematurity, et cetera. So that's how we got to that. And as far as you consider our very restricted suggestions for the use of nirsevimab after the receipt of appropriately timed vaccine, and that you consider that these are both antibody paint, and that the antibody paint will wear off. And it doesn't change the epidemiology of RSV disease. And its goal is not to prevent RSV infections in every individual. It can only reduce by a certain degree the morbid consequences of RSV disease. So people have already, pediatricians and others have already been concerned about our cut points for nirsevimab and our cut points for this. And they are based on data. And because this is not a vaccine that will change the epidemiology, prevent herd, prevent long-term protection, we have to have those to make them both cost acceptable, because these are extraordinarily, probably unreasonably priced products. And we would say, bring on competition to bring these down. And the last thing I need to say is that isn't the United States really fortunate to have such people as Dr. Fleming, Dutra, and Jones, people of such high purpose, capability, and a willingness to stick with all of this to give us such clear information upon which you can now make recommendations. Thanks very much.
Thank you, Dr. Long. Dr. Talbot?
I think this might be the most complicated vaccine recommendation for young adults that we've had in a long time. And I worry about the complication, the time period. I know we give flu and COVID during that season, but we give it to everybody, regardless of where they are in their pregnancy. So there's a lot less of a needle with those two vaccines. I also am a little bit worried in the adult world, if you get the same vaccine twice, you pay for the second vaccine. So if a mother has or has not gotten she's gotten her RSV vaccine, but is confused because she's gotten 4 vaccines or 2 vaccines or 3 vaccines. And the pediatrician's kind of left in this position to give the child the antibody, someone's going to have to pay because that's double dipping, since we're only recommending one or the other. I think it's really interesting that mothers don't want 4 shots. They want less than that. So I guess I'm asking, what's the benefit of this vaccine? If we're going to give every child antibody, why do we need to recommend it at all? So I'm hoping the work group can help me work through that struggle.
Okay, we're gonna so park that question for a moment, unless Dr. Long, do you want to respond right away?
I'd be happy to respond to say that it's always good to have 2 products. We don't know what manufacturing will be like in the future. We don't know if the first year of use of one or the other will make us more hesitant to use one or the other. So it is always good to have 2 products to start with. And I think that's all I'll say about that right now.
Thank you, Dr. Long. Dr. Paling?
Thank you. And I have a couple things to say, but one is I would like to respond to Dr. Talbot. And in speaking to parents who have recently given birth, there are some that would prefer to take a vaccine rather than have their child get a shot. And then there's also all kinds of cases that I've had recently, including one where the father of the child had a significant bleeding disorder. And so they didn't want the child to have any sticks for any reasons because we didn't know if that child was going to have a bleeding disorder. So there's going to be multiple cases like that. But you are absolutely correct. There is a lot of complexity and a lot of clearly documenting the information so everybody knows what has and hasn't been received is going to be extraordinarily important. And it builds on what you've said in last meetings, that having an immunization registry for all is desperately needed. All right, so now I'm going to move back and say a special thank you to each of our presenters who've done a fabulous job. And a thank you to Dr. Long and your entire committee, because the presentation was very helpful. And I am agreeing with your perspective. I wanted to go to Dr. Peacock's slide on the insurance. I think you showed a slide where 52% of persons who are pregnant have private insurance, 41% have Medicaid, and 4% are self-pay. And in that, I think we need to dive a little deeper into it. I can't tell you what slide that was. But one of the questions, I've got 2 questions. One is, first, let's talk about private insurance. The ACA does say that they have to cover the vaccine, but that's not immediately. And do we have any data on how many private insurances are paying for the RSV vaccine for adults over 60 years of age?
I'm sorry, I don't have any data on there.
Okay,
There's
no data.
Is it possible that ACIP is on the line and they have that information? I'm not sure.
Hi, this is Jessica Greb with ACIP. I don't have that information, and can try to get it to you if we have it. It may be relatively early, but I'll look into that.
Okay. But it's important for people that are listening to understand that there is a delay before insurance companies actually pay for it. The second is I wanted to get into the Medicaid, the 41% Medicaid, because if you're less than 19, which means 0 to 18 on Medicaid, you fall into vaccines for children. But if I'm understanding Dr. Peacock correctly, if you're over 18, so 19 and older, it would be in the 317 funds. And if I'm not mistaken, the 317 funds have recently been decreased. And so if you could talk a little bit more about that, that would be most helpful. Thank you.
I'll actually let our CMS colleagues maybe answer the Medicaid question, but as far as the no insurance, so this 4%, yes, there's very limited availability of funds through the 317 program. Those funds haven't decreased in amount. However, there are more vaccines that are potentially could be paid for uninsured adults through our 317 funds. And so really there's very limited availability in the big scheme of things to be able to pay for additional vaccines through this limited pot of 317. And I guess just for context, the 317, basically, we give a portion of funds to all of our immunization awardees so that they can purchase some vaccine. Typically, this is used for uninsured adults. Sometimes it fills in some gaps related to children, and then it's also used for outbreak funds. So it's a fairly limited amount of money, and yeah.
And this is Mary Beth Hans from CMS. I can follow up on that just to reiterate what Georgina said, which is that Medicaid will cover the vaccine when it for those who are covered under the CDC ACIP recommendation, and that coverage is separate from the 317 program. So Medicaid adults who have coverage, it will be covered through the Medicaid program, which, as you know, is a matching program with states, and that is separate from the 317 program.
Thank you. Let's go on to Dr. Sanchez.
Hey, before we go, can I ask a quick related question?
Okay, go ahead, Dr. Talbot.
For the states that did not opt in, will they still be able to pay for the vaccines for Medicaid?
So by opting in, so the Inflation Reduction Act requirement is across the board. So that brings coverage to everyone. If you're thinking of, if the opting in is to the Medicaid expansion, those people aren't on Medicaid. So am I hitting it all, the question?
Yes, you hit it perfectly. Thank you.
Okay.
Thank you. Let's go on to Dr. Sanchez.
Yes, hi, thank you. And I do want to echo Dr. Long's, the Catherine and Jefferson who led the work group just have done an amazing job. And actually all of the presenters, because they've really detailed the complexities really of not this vaccine to pregnant women, because actually, if we were only discussing and I know we're only voting on the PreF RSV vaccine for pregnant women, but in actuality, as a practicing physician, there's another option involved. I mean, if it were just a vaccine, I think it would be, if the implementation is, obstetricians and healthcare professionals who care for pregnant women are very adept at recommending vaccination, and in the time of September through to January, it's already been, they already have that experience, as was brought up in the work group. But I think that, and overall, I will say that I am reassured by the preterm birth data when the vaccine is given at the 32 to 36 weeks gestation, even though I will say that late preterm births is still not optimal if it were to be real. So I do think that it'll be really important to monitor real-time data on preterm births as is being planned, because we have to remember that in the vaccine trial, only low-risk women for preterm births were actually enrolled. And so I really think that we really need real-world data when women who are high risk for preterm births are also included. But I will go against a little bit of what's been discussed, because I actually was one of the ones in favor of the shared decision maker, because I think there are two options that need to be discussed with the pregnant woman, because it's not just the vaccine at 32 to 36 weeks, but she needs to be told also that the other option is nirsevimab, and that, and I can imagine as a pediatrician taking care of a baby who I then tell the mother that this baby cannot get nirsevimab because she had chosen to receive the PrEF RSV vaccine. And so I think that that discussion, irrespective of what is easy or not easy, and what the obstetrician and healthcare provider for the pregnant woman decides, I think that discussion must be had. And it's been stated already, but I think that that is important. And so when I think that there's a variety of options to be discussed, I think shared decision-making is the way that I would prefer. And I guess my question then, Grace, is will there be an option to vote on that?
Well, I was going to pause and ask if the team would put up the vote slide, but I did want to respond, Dr. Sanchez, as a member, and just say that in my opinion, every recommendation should really be a shared decision, similar to all medical care that we provide. I think the distinction about the recommendation is not whether or not the process occurs. It's really more about sort of more of a universal recommendation versus more of a selective recommendation. So I don't think that a full recommendation means that this discussion shouldn't happen. In fact, it should with every pregnant person to make sure that they're aware of the options. That's my opinion about it. And I don't think shared clinical decision-making changes that. I think it just restricts the access for certain patients. So with that, I'm actually and I'm not gonna necessarily answer your question yet. I will say, as you know, there's always the opportunity to do an amendment, but what I'd like to do is focus on the vote language on the table in the moment, and actually ask Ms. Bata to raise her questions or comments. And also, if you wouldn't mind, Ms. Bata, starting us off by just commenting on the vote language and your thoughts about it as well.
Thank you. I fully agree with Dr. Talbot in regards to this being an incredibly complex situation where we have two products given two different times in two different audiences, but should only be given to one or the other audience. And the feasibility of this, I think, is really challenging, as I know from the colleagues in my own health department are struggling with how to implement the nirsevimab and how to reconcile that if the PrEF is also recommended, how to coordinate that. And I also want to emphasize something that Dr. Peacock mentioned, and that's related to the 317 funds. They are incredibly restricted, but not only that, programs are implementing the seniors RSV, which is also a very costly vaccine. And will be in very limited supply. So there will be a lot of competition and probably very little supply or availability of that vaccine for either audience. And so I think that's an ongoing issue that we need to keep thinking about. In terms of the recommendation, we have two really wonderful options for protecting our infants against RSV. And so it's hard not to be supportive of this. I am supportive of this. And I think that, as you said, Dr. Lee, every single vaccine that we are providing to our patients needs to be explained. It needs to have some form of discussion beyond giving the vaccine information statement. And so I don't object to this, but I am very concerned about the feasibility of implementing this. Bata out.
Thank you, Ms. Bata. Dr. Lear.
Thank you. I'd like to especially thank the work group for coming to a seasonal recommendation, which I strongly support. It was what I was thinking, and I was glad to see that it came up. Another side comment, you've heard me be concerned about insurances being delayed in implementing vaccine recommendations from the ACIP. I'd like to turn around and at least thank one vaccine that has been nirsevimab, one insurance company that has been very slow to implement recommendations is doing that effectively immediately. And so I do want to thank the insurance companies that are covering nirsevimab quickly, because I think that's very critical to get that out this season. I would like to comment on the proposed voting language. I'm fully in support of it. I have a question for the work group. Was there ever a consideration of adding a line that said this recommendation is for infants not intending to receive nirsevimab? I think that's actually very important, because if an infant's going to get nirsevimab, I'm not really recommending maternal RSV vaccine. And I think it would be reasonable to put that in the actual language. But maybe there are reasons that I'm not aware of that wouldn't be a good idea. Thank you.
Why don't we keep going, and then I'll ask if the CDC team and/or Dr. Long will comment afterwards. I just want to make sure we get enough comments about the. Dr. Pilling put her hand down. So, Dr. Long, the floor is yours.
Yes, I think that if thanks, Dr. There, you're always so very careful. Appreciate it. If we put that language in there, it would be tacit implication that we might not prefer this vaccine. And at this point, this year, not knowing more than what we have from efficacy studies and safety concerns, I don't think we would want to do that, but it would be something that as Dr. Lee said, I think absolutely appropriately. We did not for a minute think that this would not be shared decision between doctor and patient, just not rising to the level of a policy decision that there must be a decision based on differences of outcomes or risks, et cetera. So that I think it would be best considered in the clinical considerations of, you probably wondered, as I did the first time I heard it, how in the world could you ever decide to withhold nirsevimab, this because you were giving nirsevimab, or give the vaccine on top of the plan for nirsevimab, because they're happening at different times in pregnancy, obviously. And it would be that if you had a patient who you knew in utero had significant congenital heart disease, I would want you, and we had nirsevimab around, and we hadn't found that there was any safety issue, you would want to save that person for nirsevimab, so that they could get it immediately, et cetera, and then save the money and the risk of any potential risk of giving them vaccine during pregnancy. So I don't think I'd be in favor of the spirit of it, but not in the language of it, Dr. Lair.
Thank you. Dr.
I will
Bailey.
just compliment
Oh,
that.
sorry. Go ahead, Dr. Jones.
Thanks. We agree. We think it's covered in clinical considerations and will be emphasized in our education materials and MMWR, et cetera.
Thank you. Dr. Paling?
Okay, so I would like, I very much appreciate this conversation. And like Dr. Lair, we in North Carolina have one insurance company that has agreed to pay for nirsevimab in the outpatient setting. We're still waiting on the inpatient setting. So that is just where people are. And I am worried about the cost and who's going to cover it. So I do think this is a very important option. And so I would like to make a motion to accept the voting language as it is written. Thank you.
Thank you. We have a motion on the table. I will ask for a second. Dr. Sanchez.
I wasn't going to second it.
Okay. Go ahead. If you have a question or a comment, please go ahead.
I had a comment. No, and just thinking about what Dr. Lair had commented, which I agree, it is what we have discussed for the clinical considerations. But as I think about it, actually, a fetus, we've diagnosed severe congenital heart disease, for instance, or some other malformation that may be beneficial to really provide more substantial protection. Actually, that infant is likely to stay in the NICU or the cardiovascular, the CTICU for a prolonged period of time. And actually, thinking about it, nirsevimab would not be given until discharge. And although we try to prevent RSV infection in these units, it does occur. So I'm just thinking that actually some of those babies may actually benefit if they have maternal antibody, at least through the time of discharge. So, and in those infants, we have recommended that nirsevimab be given even irrespective of whether the mother got vaccine. So I'm just throwing a different angle to that. So I think that it'd be best kept in the clinical consideration.
Thank you, Dr. Sanchez. Dr. Lair.
I would like to second the motion to approve the language as shown on the screen.
Thank you. It's been moved and seconded that we adopt the recommendation language on the slide. We will continue on with our discussion as I think we have a few more comments. Dr. Long, over to you first.
Very quickly, Dr. Sanchez, who's been so helpful in having us understand all aspects, especially of perinatology. We do not want to give a monoclonal antibody or any other kind of a thing to protect people in the nursery. We want to have infection control to do that. If infection control falters, then we can give it. I would be as concerned, Dr. Sanchez, about your protection from your mother is going to be long gone before you get out of the nursery if you have severe congenital heart disease. So there are two sides to that, but thanks for bringing it up.
Dr. Cotton.
Thank you. I think I should state that because I was a little late to the meeting due to overlapping meetings, I'm Camille Cotton and I'm from Massachusetts General Hospital. I have no conflicts of interest, and I would just like to state my support for this current proposed ACIP voting language. It's clear, it's easy to understand, and I think that that is imperative for the public to really be able to clearly understand what we are recommending. So I support this, and I actually, in that context, would not would not like to support shared clinical decision-making, because I think that has been very confusing. Thank you.
Thank you, Dr. Cotton, and thank you for self-declaring. I appreciate it. Dr. Hughes.
Thank you, Dr. Lee. I just wanted to clarify related to the shared clinical decision-making comments that in fact obstetricians are quite experienced and routinely perform counseling for all patients who receive vaccines, and this would be no different, and would agree with Dr. Long's assertion that for that reason, this does not rise to the level of a shared decision-making policy discussion and would support the full recommendation on behalf of ACOG.
Thank you, Dr. Hughes. Dr. Sanchez?
I just wanted to clarify, I by no means feel that nirsevimab should be given while the infant is either in the NICU or CTICU or wherever in the hospital, but rather it should be done at the time of discharge. I absolutely agree that infection control, infection prevention is the way, and I agree with Dr. Long. Unfortunately, some of those infections do occur, and I'm just thinking that as I process this, that if that term baby had maternal antibodies, at least for the first several weeks before they have their surgery or bypass, that it might also be beneficial, even though the risk there should be low because of our infection prevention practices. But I do not think any baby should be getting nirsevimab before discharge.
Thank you, Dr. Sanchez. Dr. Talbot?
So I'm slightly confused, not surprised. If this is not a, whatever we call the joint discussion about, recommendation, are mothers and providers going to give this to women from 32 to 36 weeks because it's recommended, and then those children are not eligible to get antibody? Is that what we're doing?
Can we ask Dr. Jones, do you want to clarify from clinical considerations the discussion?
Grace, one second. Kip, could you repeat the question? I'm sorry.
Yeah, I'd be happy to. So if this is not shared clinical decision-making, and it is a recommendation that pregnant women between 32 and 36 weeks receive vaccine, that means we are telling all of our obstetric colleagues to give this vaccine between 32 and 36 weeks. Does that mean the children, unless they have cardiopulmonary disease as evidence on echo before birth or ultrasound before birth, does that mean they can't get monoclonal antibody? And I guess why I ask this is because if you get it at 32 weeks and it's almost RSV season and you wane and it's now the end of RSV season and you don't have antibody, you don't qualify for monoclonal because your mother got vaccinated, and because we've recommended vaccination. So that's, I think, my question.
Dr. Jones, I'm going to go to you first and then Dr. Long.
So we are talking about the voting language and then the clinical considerations. So as has been discussed by many, and we did, including Dr. Sanchez, have some different opinions within the work group. The majority felt that with the voting language as is the voting language for the vaccine, but really the slide as currently shown, it's that either product is recommended and administration of both are not needed. And so while it is recommended in that voting language, it really is an option of both products, and that discussion should happen at the time when deciding whether or not to vaccinate the pregnant person.
I think, Jefferson, you meant to say either, not both. Or you meant you discuss both, but you decide on either. I think, Dr. Talbot, it would be presented as, first of all, if the mother chooses the vaccine, then you say at birth the baby doesn't need it. And that's true. The baby doesn't need it. We have made the restriction on the use of the vaccine such that there should not be but a rare infant whose vaccine antibody wanes, where the monoclonal, the nirsevimab, would have been better. There should not be but a very unusual circumstance of that. So it's not that, oh, by the way, you chose this, you didn't know what you were doing, and now you have the disability. It's that it would be unreasonable to think that you could give at choice both products. So it is true. The mother has a choice. It's just merely a choice. I'm thinking about, different colored shoes, different heights of the heels, they're just different. And some will choose to take the vaccine themselves and protect their babies, and some will choose for their babies. And we don't know this season, especially when it will be so messy about who has what and who pays for what. We really don't know who might be in a slightly advantageous, because we just don't know if there are risks, and we don't know what the effectiveness of these will be. So we're trying to make sort of the best possible recommendations for the most people.
Thank you, Dr. Long.
Sorry, Dr. Lee, if could.
Yeah, sure. Dr. Jones, go ahead.
Hopefully comment a little bit. So, this is in review, but the rare situations we're talking about, right, are those where we don't think there's enough antibodies, either because they're not produced after vaccination in a pregnant person, or there's decreased transplacental transfer. So those ones are specified. And then if we could go back 2 slides to slide 6, that because of the seasonal administration, and this is echoing what Dr. Long just said, that for those that will have potential waning of antibodies and waning protection by the time the RSV season really peaks, because we're recommending from September through January, the infants born to those mothers will be born during the RSV season. So the concern about waning is also much, much less so, since infants who would be born during that time will have not been vaccinated. And so they will be recommended for nirsevimab.
Thank you, Dr. Jones. I'm going to actually just jump in here for a moment and ask if there's any new comments or points or angles people would like to make a comment on. I did want to jump in, if that's okay, Dr. Sanchez, and reflect on the discussion around the cost effectiveness. So with regard to this vote, I do believe this is a good vaccine product with a favorable benefit risk balance, and particularly with the efforts to mitigate potential risks. So this is an excellent option to protect infants from hospitalization. I will also say, if we didn't have monoclonal antibody available, such as nirsevimab, I think, the cost effectiveness conversation might have been slightly different. I did want to articulate that the struggle with cost effectiveness, which, always is an important domain in my mind, and the questions about cost, because the decision is sensitive to this domain, is one that I think the committee, we reflected on it during that session, but I just want to take a moment to reflect on it again. The intervention itself and maternal vaccine development in general, I think, are incredibly important investments with regard to where we need to head in terms of our vaccination programs as a country. But I also just want to recognize that cost effectiveness is about value, and it's about the value of the vaccine and the value of the investment. So I actually wanted to highlight that the vote that the work group had proposed to consider seasonal dosing of RSV vaccine was really helpful to ensure we're sort of making the investment as worthwhile as possible. It is still a high-ish cost effectiveness ratio, recognizing we don't have an explicit threshold by any means. I will say it is one of the more expensive interventions we have recommended. And so I, want to just call that out, that the seasonal dosing is a way to kind of at least get that to a more reasonable range for us. But I also wanted to just make the point from the earlier conversation that I think our committee's role is really only to comment on the value of this vaccine in the US. And I, as we learned during COVID, having products available, such as these RSV vaccines or passive immunization, become more available to low and middle income countries that might not otherwise have access is something we need to consider. So I really would encourage our manufacturer colleagues to consider how such innovative products can be made available in countries at an affordable price. Recognizing that each country is different, but also recognizing that there is a greater responsibility from a public health perspective. So that's all I wanted to say. Dr. Sanchez, back to you.
Sure, Grace, you can, as the boss, you can interrupt or go ahead. But no, I think one of the problems, and it's impossible to consider this vaccine in isolation, because the fact is we have another product. And unfortunately, at the present time, we don't have any head-to-head trial comparing the two with respect to either efficacy or effectiveness. And I do think that Dr. Talbot is right in that, the discussions that need to be had with the parents and with the mother, the pregnant woman, because there are options. And I guess, and I understand that each medical decision should be a shared decision making, but I just would really push for that discussion to be had with the pregnant woman as to whether she prefers getting the vaccine or whether the infant will not, because it's real. I mean, that's going to be the majority of our patients, because it's true, if she needs to be told that if she gets the vaccine, it's very likely that her baby will not get nirsevimab. And there should be a lot of education about both of those. So yes, I think this shared decision-making needs to be part of the discussion. Thank you, but I wanted to just comment on that.
Thank you. Can I ask our CDC colleagues if, for example, there will be a vaccine information statement that would cover both options as part of that discussion?
Just a second, I'm passing to Dr. Peacock, who will address that question.
So there's going to be a suite of materials. For nirsevimab, there isn't actually a VIS. There's going to be an information sheet because it's not a vaccine, but there'll be a suite of materials that will be able to be used in these conversations.
So, for example, a tool that would actually incorporate both products as available and as a choice for the pregnant person?
Yes.
Okay, thank you. Dr. Lair.
Thank you. A couple of comments. Dr. Long just reflected that she feels that it's a fairly equal choice between, I'm interpreting, between nirsevimab and this vaccine. And I actually want to sort of go on record that I still believe that if a child is going to get nirsevimab, that is better. I think it's better because we seem to have evidence that it's better efficacy. It's definitely more cost effective. And so I don't really want it to be an equal representation. I recognize we're not going to make a preference. And I recognize that we need a lot more data over the next couple of years to see in the long run which is better. I doubt we will ever get head-to-head information, but I don't want it to sort of be that you can get this one or your kid can get the vaccine, nirsevimab. If I'm presenting it to a pregnant woman, I'm going to say, if you want to give your kid nirsevimab, that's what I recommend. And if you don't, then this is another option. That's just a small nuance on what Dr. Long said. With regard to Dr. Sanchez, I would go back to what the work group said. I see shared clinical decision-making when you have a good product that has some drawbacks that the person should really know about. And so I could see where you might say nirsevimab is better, and so that's a drawback. But really the classic one for me is where we have RSV for adults, and I'm spending a lot of time telling people about this potential neuro complication from the vaccine. So I recommend the vaccine, but there's this possible problem with it. That's where I would use shared clinical decision-making. So that's why I don't think it quite rises to that level. Thank you.
Thank you. Dr. Sanchez?
In response, no, and I agree with Jamie, but I do think that that the signal for prematurity was of major concern, and not just to me, to the work group. And I do think that the FDA did help us out with that by going to 32 to 36 weeks. But I do think if it is something that needs to be monitored and surveillance performed post licensure or post post recommendation, then that is something that the pregnant woman needs to be aware. And so that discussion needs to be had. So that again, I'm a little bit more comfortable with the prematurity risk, but certainly I would not have been if it were a vaccine for 24 to 36 weeks. And so I think that's where my clinical decision-making aspect came in, but I'm slowly coming around. Thank you.
Thank you. Dr. Bell?
Yes, thank you. I just wanted to add my voice to this issue that you just alluded to, Dr. Lee, and Dr. Lair just talked about, and that is the question of the options, the two options. And we've all said how complicated this is. One of the ways that it's complicated is that for many women, their doctor during their pregnancy is not the same doctor as the person that will be taking care of their child. And I think that this whole idea of informed decision-making and the fact that the parent gets to decide in consultation with their physician, and because of all of the data that we have accumulated about the importance of the recommendation of the doctor, means that we really have to be very sort of on it in terms of making sure that there are the tools available to help physicians help patients make an informed decision between these two options. And that's something I think that our partners and the professional organizations can really help with. But I think that is really pivotal to this recommendation fitting into things in the most optimal way. And it's a really important part of implementation. So I just sort of wanted to emphasize that again, that you can't make an informed choice if you don't have the tools to really make a head-to-head comparison. And Dr. Lair's comment is just really very important in terms of us figuring out how to do this in the best kind of way.
Thank you. And, since we have some of our liaison colleagues on, and they may or may not want to comment later, but, thinking about how the role of ACOG, AAP, AAFP, ACNM in some type of a shared statement around implementation could be really helpful to both communities, and particularly because this is a sort of new era for where we need to head in terms of both decision-making as well as implementation. Dr. Talbot?
I worry because we've asked women to get Tdap and only half of them are. And this year we're going to be like, please get COVID and please get flu. And oh, by the way, we have to have a discussion about RSV, but I don't really know the treatment on the kid side. I know what you could get in the adult side. And I have an information sheet for the RSV vaccine for you, but I don't have the information sheet for the kids monoclonal, and they're not going to talk about the other one. And you do adult vaccines and there's no registry and not, at least not complete registries. I just feel like this is going to be incredibly complicated, and we have a great option that we can give children that will protect more children, that is more cost effective. I think this is an incredibly complicated, expensive, like way out of the atmosphere expensive. And I don't know that we're going to get much benefit except to provide confusion about, did mom get vaccine? Did mom not get vaccine? Did mom get vaccine but delivered too early? This is incredibly complicated, and I don't think it's going to improve care. I think it's going to make providing care more difficult. If we just say the child should get the monoclonal, we have a very simple recommendation. It's a cost-effective and very effective mechanism of protecting the child. But when we add all these other variables, what we're going to end up with some children not getting monoclonal who need monoclonal. And I think we're going to put children at risk by doing this very complicated recommendation. So I'm done.
Thank you, Dr. Talbot. You know, I'm going to just take a moment to, I'm going to put on my CQO hat for a moment and just say, there are definitely gaps that I think all of us can see here, which is the concern that we're sharing as a committee around the complexity of these recommendations. But I also just see this as a tremendous opportunity for us to think about how we would want to provide care in a different way. I recognize this is not going to be the answer to that, but I do think it's stimulating a bunch of really important conversations that we need to have about the gaps that exist and how to really make care better. So as our industry partners are continuing to innovate in this space and build out broader and more comprehensive prevention programs for women, pregnant people, and their infants. And as you know, our delivery systems are learning to work together to be able to support decision-making in this complex way. And as our immunization registry and our public health systems are thinking through how do we make sure that we're linking these data that are sorely needed and optimize our prevention capabilities and not, waste important resources because we don't have that information available. I mean, I think this is exactly the direction we need to head. It's not going to be easy, but I think we shouldn't shy away from it because it's difficult to do. That's just my 2 cents.
And Dr. Lee, I agree that we need to move forward, but we're not there. We do not have adult immunization registries in every state. So using this mechanism, we may put children at risk. And so I think we need to put in the adult immunization registry first, and then we can play around with all these options. But I really worry we're going to leave kids in a gap.
Yeah, I definitely hear you, Dr. Talbot. It's the build the plane as you fly it challenge we continue to have during this pandemic. Dr. Long?
I hear both of you, but I don't know why it would put children at risk. Hear me out a little minute. Because we have been mute on the point of how do you know that the mother got vaccine and then you would withhold nirsevimab, because we know that this year, especially, the registries won't be perfect. And we have really, by being mute, allowed tremendous flexibility for the doctor to say, I'm not convinced this mother got this vaccine. I'm going to give nirsevimab, and that would be perfectly acceptable under our recommendations. So how maybe I'm missing something. I don't understand.
Sarah, the thing is, if we make a recommendation for one or the other, insurance is only going to pay for one of them.
Right.
So if mom got the vaccine that the pediatrician did not know about, that means that mother is going to get stuck with a $500 bill for the administration of the monoclonal antibody. So some moms who may be confused about what vaccine they got may say, yeah, and I'm not risk, I don't want to do that. And I will tell you, for someone who's done flu vaccine verification for a long time, patients say, yeah, I got that, but it was actually a different vaccine that the provider gave them and they got confused. So they're going to be moms who think that they got this, but they didn't.
Okay, thank you. I think, we are essentially at time. I'm going to call on the remaining hands that are up. I'm just going to ask if you can please focus on any new issues that haven't been discussed. Dr. Paling.
I'm going to just take a moment to share that as a newborn provider, I evaluate the charts of moms and babies, and this can be done. It will not be easy, but it's definitely doable for the benefit of all families. Thank you.
Thank you. Dr. Sanchez.
I just wanted to agree with Dr. Long as well. I think that I don't see where there will be a risk. And actually, I think part of my hesitation and indecision is because, and getting back to Dr. Lair, is that we all have personal preferences, and we look at the data and we look at the efficacy of the trial of the two trials of the PreF vaccine and also of nirsevimab. And unfortunately, the endpoints were different. So we can't even compare the actual, head-to-head in many instances in terms of primary outcome. But I think we all have preferences for one or the other. And I think, and I have to come back to the point that what we're doing is voting on this vaccine, not on how it's going to compare to nirsevimab, because ultimately we need that to be studied. Thanks.
Thank you. Dr. Hughes?
Thank you. Just a couple of quick points, I think, of clarification. One is that it is absolutely routine for us to, as obstetricians, and to collaborate with our pediatric colleagues to review maternal charts. It is done every day regarding testing like hepatitis B testing. The results are always communicated. And so while we recognize that there is some complexity to ensuring that the charts are complete related to receipt of vaccine, it's quite doable. Also acknowledging the fact that this is fairly complex, and we at ACOG, along with our CDC colleagues, the Society for Maternal Fetal Medicine, plan to partner with other entities like Mother to Baby, American Academy of Pediatrics, AAFP, and ACNM to ensure that there is a solid implementation strategy to assure that these challenges are met.
Okay, thank you. Dr. Cieslak.
Hi, thanks. A couple of comments and a question. First of all, I agree that I think this is going to be pretty confusing recommendation and difficult to implement. Secondly, the way I understood Dr. Jones to approach the way the decision would be made is that if an infant presented in the fall, a pregnant woman presented in the fall, then vaccination would be given. And then if not, nirsevimab would be given. And I know there wasn't a head-to-head trial, but looking at least RSV medically attended illness, the nirsevimab seemed to be better. And so it seems to me that effectively we're saying that nirsevimab, which may be better and is more cost-effective, is going to be given to the kids who are at lowest risk of the disease, so that the kids at highest risk are possibly going to get the inferior product. Then I have a question, and that is, if we're delaying vaccination until at least 32 weeks of gestation, it occurs to me that the infants who are at highest risk, namely those born very prematurely and likely to suffer bronchopulmonary dysplasia, will not be benefiting from vaccinating the mother. And I'm wondering if that was taken into account in estimating the benefits of vaccination and the incremental cost effectiveness ratios. Thanks.
So hi, this is Dr. Fleming-Dutra. So just to respond to a few things, I do want to emphasize that in the clinical considerations as proposed that, we are carefully noting that while it would be rare in which there would be situations that children would get both maternal vaccination or nirsevimab, that we are emphasizing that flexibility is needed for providers to be able to provide nirsevimab when they feel that it's clinically warranted. Additionally, regarding your comment, Dr. Cieslak, we want to make it very clear that, again, it's important for pregnant people when they are making the decision during pregnancy, should this vaccine be recommended, whether they would receive the RSV vaccine or nirsevimab, that conversation happens. And it would not be, I just want to clarify that. So if a pregnant person presents, there are 32 to 36 weeks during September through January, that conversation should happen whether they would prefer to receive the RSV vaccine, should it be recommended, or nirsevimab. It's not that one would be preferred at a certain timing. And then lastly, the work group did extensively talk about that with this approved dosing interval of 32 through 36 weeks, and that it takes at least 2 weeks for adequate maternal antibody production and transfer. That means that all children who are born at less than 34 weeks would receive nirsevimab, and that was taken into effect in the cost analysis.
Thank you.
And I'd just add to that for Dr. Cieslak that the purpose of maternal vaccine is not to prevent RSV in premature infants.
Thank you. Really brief comments, Dr. Lair, Dr. Sanchez, and then we're going to close.
Very brief. I am amazed at the number of my patients who carry around their COVID vaccine cards and their children's COVID vaccine cards in their on their person. And so I wonder if Pfizer would be interested in creating a RSV for vaccine cards that could be used during pregnancy and could be given to the pregnant people and then shared at the pediatric office. I think that might be a very easy way of sharing information. Thank you.
Thank you, Dr. Lair. Dr. Sanchez.
No, and that was exactly my point. I mean, we all have our COVID vaccine. It's on my phone. It's, it's a photograph on my phone. I had to show it every time I went to the theater. And I think that having a card that says whether that the mother was vaccinated and telling her at the appointment, put it on your phone, I think would be really helpful. And I just want to echo what Dr. Long said. The maternal vaccine is not meant for the preterm infant or the infant who develops bronchopulmonary dysplasia. We have another product that all of those babies will receive, and nirsevimab. So this is not looking at the so-called high-risk group because that's not the goal of this vaccine. Thank you.
Thank you. And with that, we're going to move on to Dr. Jeannie Santoli, who will present on the Vaccines for Children resolution.
Hi there. Next slide. So we're going to walk through this, and I want you to just note that the language that is shown in red font is the language that's new from the resolution that you approved in August. So first, the purpose of the resolution is twofold: to add an RSV vaccine for pregnant people aged less than 19 years to the VFC program, and two, to update the language regarding the recommended vaccine schedule for nirsevimab to take into account RSV vaccine for use during pregnancy. Next slide. The eligible groups, pregnant people aged less than 19 years. Next slide. The recommended vaccination schedule and intervals, and this is language we have been reviewing. I'll read it to give people a chance to see it. Actually, I think I won't read it. I think I'll let you all read it. That will be easier. Next slide, please. The recommended dosage, refer to product package inserts, and the contraindications and precautions refers to also to the product package insert. Next slide. So now we're coming to the nirsevimab component. The only change here is just that we didn't have two components before, so this is now component B of the resolution. Next slide. No changes to table 1. Next slide. For the recommended vaccination schedule and intervals, there's some language that's been added to the children who are recommended for RSV in their first RSV season, and that's shown in red on this slide. The rest of the language is the way the resolution was in August. Next slide. this additional language has been added. There's some language actually in each component of the resolution that refers to the other component. So the vaccine also refers to nirsevimab, and the nirsevimab component refers to the vaccine as well. I'll give you a chance to review this language. Next slide, please. Again, this is unchanged. Next slide. And this statement is unchanged. This is a statement that references the recommendations that will be published later. And it's standard in all of the VFC resolutions. Thank you. I think that concludes what we wanted to share.
Thank you, Dr. Santoli. Are there any questions for Dr. Santoli on the VFC resolution updates? Dr. Paling?
Yes, thank you. Dr. Santoli, thank you for doing this. Would you go back to slide 9, please? Or the one before that? Yes. I was wondering if we should say who, because you would want to give nirsevimab if they not received the vaccine, if the vaccine was unknown, or if they were born within 14 days.
So we can certainly update that to include the one that's not stated there explicitly.
Okay, thank you. I appreciate it.
Sure.
Yeah. Dr. Lear?
Thank you. I forget, do we need to make a proposal, or is this automatically proposed if it's presented?
No, I do need a motion to approve the updated VFC recommendation, if you would like to.
I would like to make a motion to approve the updated VFC recommendation as presented in these slides. Thank you.
Thank you, Dr. Lear. Dr. Paling?
May I please second that motion?
Thank you. It's been moved and seconded that we adopt the recommendation language on the VFC language in the slides. So we will return. Any other questions or discussion? Thank you. We will return to the vote after public comment. But at this point, what I would like to do is to take a short break. So I want to thank our presenters for an outstanding set of presentations and my colleagues for the excellent discussion. And what we will do is take a break until, let's say, 33 minutes after the hour. You have 5 minutes. I'll see you back at 33 minutes after the hour. Thanks, everyone.